But let's just jump right into the first question. And we'll start with Ray, and then we'll take it right down the line. Where do you think value-based care is today? What do you think the future challenges are? And where is your organization in this movement?
Yeah, and thank you, Larry, for the opportunity to be here with you all this morning or this afternoon. I will call out the Florida Blue folks, GuideWell folks that are in the audience that I'm aware of. If I'm not aware of you, please stand and wave. Pip Randall, right here in the front, and Pip works in our GuideWell Health organization. We have Lana Lenzini, Director of Value-Based Contracts. We have Jennifer James, Value-Based Contract Director, not Contract Director, Value-Based Performance Director, sorry. We had Suzanne. I don't see her here. Anyone else from GuideWell or Florida Blue in the audience today? So thank you all for coming. So really, I think for me, whenever you think about where's value-based care today, it's an exciting place. We're more than a decade into the transition from volume to value. Most payers have value-based contracts of some type. Many providers have agreements that they have in market. You have a lot of companies setting goals around aligning members to these contracts in the market. We're one of those companies. We work a lot with the Healthcare Payment Learning and Action Network, who have really defined goals for the industry to align lives to risk. Very bold action from CMS to align 100% of beneficiaries in near term to value-based agreements. We're right there. We've got a goal for 2 million lives aligned to risk by the end of this year. So, we're really doing a lot in that space. You see a lot more progress maybe in Medicare and Medicare Advantage than commercial, but I think, we're very, very prominent in our commercial value-based models. We've seen a lot of savings from the models. Whenever you look at total cost of care risk arrangements scaled across the state of Florida over the past several years, we see consistent return on investment and consistent value and benefits for our members. Whenever we look at condition-based models like episodes of care, cancer care models, kidney care models, we see more opportunity maybe at a per-patient level. So a lot of work trying to integrate and knit all of that together. We do see that independent physicians appear to be performing better over time. We do see that models that have risk, downside risk, create more engagement in the provider community. And I would also say that COVID has not left us out of impacts whenever you think about how do we measure care, how do we do the things that we do in value-based care. So just kind of thinking of the future really hinges on how well we can align and re-engineer the payment of the healthcare dollar to value and really do it in a way that reinforces outcomes for all providers. We're not talking about primary care physician-only models. We need to integrate across the entire delivery system. The other thing I'll mention is that COVID-19, again, you've heard this, but exposed social determinants of health as a really critical need for our models, healthcare disparities, collecting data about race, ethnicity, language spoken, and using that information to understand where there are healthcare disparities, where we can implement solutions. Also, behavioral health has been very important in what we measure for quality of care and making sure that access is there. So I know this is like 4 questions in one, Larry. It's okay. I got 2 more answers for you.
All right.
But I do think, for the future, we do have to impact acute episodes of care. Joint replacements are a good place to start, orthopedics, but I think also looking at cancer care, looking at kidney care, kidney disease. I think a lot of that is important, chronic illnesses, social determinants, behavioral health, unlocking all of the savings potential we have across all these models. But the challenge is measurement. It's all very complicated. So we have complex contracts with providers, and healthcare is very complicated. So whenever you say we want to be able to influence all of these things in our models, we don't want any specialists to feel like they missed out on the value-based care movement. It becomes a measurement quandary for us, just to do attribution, risk adjustment, setting financial trend targets. How do you deal with overlapping payment models? So there's a lot of things there that we need to continue to work for. And where we are in terms of the journey to value-based care, we've got nearly 2 million members aligned. We have a robust portfolio of population-based models with innovative models for cancer care and orthopedics. I say robustly supported by analytics and seasoned experts like Jennifer James and her team around the field that help providers see opportunities for improvement. So going forward, our goals are to align each dollar to risk, to implement behavioral health and social determinants of health in our models, and to evolve our programs to meaningfully engage specialists in the community.
Great. Thank you, Ray. Dr. Diab?
Yeah, thank you, Larry, for inviting me to be on this panel. And it seems like I sat in the wrong spot after Ray because he covered everything. But what excites me the most that when I hear a bold commitment from CMS, which pay 60% of the total medical spend in this country, that they are committed to have 100% of Medicare beneficiaries in a value-based care by year 2030, which is around the corner. And from what we know, history tells us that when the government moves, the whole industry moves. So that's exciting for me, that this is going to pick up momentum, because we've been working on value-based care for many years, and we need extra push to move the needle and get more providers engaged in that. I'm going to jump, on the challenges, right? And for me, it's the independent primary care physician who is practicing in rural areas and remote areas and underserved areas. These are the ones who are not organized in a clinically integrated network, and they need a lot of support to be able to work in a value-based care environment. And that's why, we got into the ACO REACH model, because we believe that this is an opportunity for us to support these independent primary care physicians who are not organized in big groups or don't have the infrastructure, whether it's a care management or analytics, to be able to help them to get into and reap the value of value-based care models. So that's because these are the folks who are serving a population that needs a lot of help, and they are falling through the cracks of fee-for-service. And again, one of the other challenges that we face as an industry is this interoperability. For a value-based care to work to the maximum potential of it, you need the connection, you need the interoperability, you need the physician at the point of care to have access to all the actionable data, and they need to see the 360-degree picture of their patient. And we're still struggling as an industry and as a nation with the interoperability of value-based care. But we as an organization, as an enterprise at CVS Health, fully committed to value-based care. And whether it's the insurance arm, Aetna, or CVS at large, we believe the value-based care is the future, and we all have to work together as payers and providers to improve the clinical outcomes, because the fee-for-service system proved to be the worst system for healthcare, and it's not working. And it's not working for the patient, and it's not working for the physician as well. So nobody's benefiting from this system, and that's why we are, as Ray mentioned, we are fully engaged in this model and investing in it.
I find it interesting. Just a short few years ago, those of us that have been in healthcare for a while, the term value-based care didn't even exist. Just think about that. What are we talking, 7, 8 years ago? Maybe? If that. Yeah. Anyway, Paul?
Oh, thank you. So, like my colleagues here said, there's a big commitment towards moving towards value-based care. Humana's got about 4 million members in value-based arrangements, with provider groups. And of those members, we've got about 82% of those that have at least 2 chronic conditions or two conditions that are affecting their health. So similar to what they have talked about, working with the provider groups, the thing that I get to do is leading the population health strategy. I'm looking at the community, that 80% of the patient outcomes that are in the community, at home, outside of the physician's office, that are really affecting the health of those members. And value-based care cannot succeed unless we start to intervene earlier and start to help people overcome those barriers to health. Things like food insecurity, the mental health challenges, the transportation, all of those things that obviously you ACOs and the people that are here really understand. But how do we continue to tell that story, not only to the provider groups, but the other stakeholders, the policymakers within a community, to really make a change? So Humana is really dedicated to value-based care. We've got tons of providers that are in it, but we're also understanding the other aspects that really play a part in the health outcomes of the members and the cost savings and all of that. So how do we encourage providers to screen for social determinants of health, to understand what's really impacting a member, and then how can we not only help them screen for it, but connect those patients to the resources in the community, so the doctor doesn't have to do it themselves, but they can point to a United Way or a food bank or somebody else, a housing stability program, to get somebody to really make a shift towards improving their health. So I think the future is exciting in value-based care. I think, you know, the data and understanding where people are impacted is really important in this. And I think to Dr. Diaz's point here, or Diab's point, it's working together, right? It's not being a adversarial relationship, but how do we work as payers, providers, and community together to really make an impact in this?
So Paul, you mentioned you have 4 million lives in value-based, and how many total Medicare lives does Humana have that represents it?
Last number's around 7 million or so.
So you're well over half of your population is in
Yeah.
a value-based environment.
Yeah, so don't hold me to those numbers.
Okay,
please.
great.
So it's just between us.
Dr. Howell?
Thanks, Larry. I have to agree with my colleagues on the panel here. I want to take a little bit different spin on this because we talk about value-based care from the perspective of practices and physicians and reimbursements and population health. But you know, value-based care doesn't mean anything if we don't get to the end player, and the end player in this value-based conversation is the patient, the consumer, the customer, whatever we choose to call them. And we've got to, in this value-based journey, figure out how we connect better with them. And that may include the term engagement, but really it's how do we connect with them and get them to become a part of this journey. See, because as a physician, I'm doing all the little things, I'm checking all the boxes, I'm doing all the surveys, but if I'm not having a relational commitment to that patient and making sure that they're on that journey with me, we're really spinning our wheels. We spend a lot of time in value-based care today trying to keep patients from doing things that are very costly and unnecessary. But patients don't really understand all of that. So if we're going to move to the next level of value care, we've got to figure out how we get them much more understanding of what value-based care, because a lot of them don't even have an idea what this really means. They need to be versed in this. They need to understand the value that comes from it. And if you've ever been in or on the patient journey, you understand that all that going on in the doctor's office is fine, but if it doesn't impact me as the end user, I really can't get anywhere with it. The other thing that Larry was talking about, how old is this journey? This journey is not that old for value-based care, and we had pretty much a 2-year stoppage, and the energy was going like this, and then it just plummeted. And we're going to have to put a lot of energy back into this system, this program, this process, if we're going to get back on the move again. I did run across a comment by Dr. Sachin Jain, President and CEO of SCAN Group and Health Plan, and it was a comment he made. For value-based care to succeed, groups must have a robust clinical, I think this was commented, and financial culture in place to ensure that aggressive practices to manage cost are pursued through the lens of the true benefits to the patient, not the financial interests of the group. The actions to which we subject patients must be guided by the radical common sense that every one of us would want to see in play for ourselves and our patients. The final comment I'll make about where we are in value-based care today, doctors, clinicians, systems of care are tired. The generations have changed. They've transitioned from what was there when I started practicing. We were talking in the hallway, 60, 70, 80 hours a week of practice. Folks aren't doing that anymore. And in order for value-based care to work, we've got to figure out how we really retool and restructure the delivery of care. because no one has the time. That 8 minutes of time that I spend with you as a patient, I can't do all the many little things that are necessary to really move you along the continuum in managing your chronic conditions and or some of your acute concerns and cares.
So I'd like to just quickly jump in on something you said, and talking about patient engagement is figuring out who the trusted person is in that person's life, is helping to tell that story. So it's not just the physician, because obviously the physicians have a lot of trust, but the faith leaders, the community leaders that really speak and can tell that story. That's an important component of improving the health of a patient, of a member of a community as well. So that's something that really can't be lost in this conversation around value-based and changing the mindset of healthcare in the country right now.
Agree. Because people aren't going to the doctor, so we've got to find out where they are getting their information. So this is all part of value-based care. We can't look at value-based care of just what goes on in the practice setting. Value-based care has to be spread out across the entire continuum. That's what population health is all about. It's not just looking at one, it's looking at all of the inputs so that you can get a better output.
Thank you, guys. We'll go to slide 2. I don't know if I'm supposed to move that or... There we go. Thank you. This is a little bit of a different question, and I think all of our panelists are going to come from it from a little different angle. And I probably should have said, are you concerned with primary care networks like VillageMD, Walgreens, CVS Health? Dr. Diab is here representing that. Walmart. He didn't know I was going to throw that question in there until he agreed to be on the panel, by the way.
Thank you, Larry.
Walmart, Amazon, United Optum, as well as all the venture private capital companies out there. And then we're dealing with hospital health systems that are capturing a significant portion of primary care practices all over the U.S. How does your organization individually, and Dr. Howell, you can start with this, plan to ensure access to quality primary care members, services, and physicians, as well as attribution of members in this value-based movement?
Thanks, Larry. So I gave that one a lot of thought. I've had a lot of conversation with ACO leadership in our organization, that contracts with our organization and outside. And some of them say, well, you know, Cigna, you should not contract with systems or these organizations because they're our competition. The reality of it is there's just not enough available access as it is. So for us to not contract with folks that can provide care, it doesn't make a lot of sense. I think what we're going to have to do is find out how we live synergistically with each other, but to also make sure that the right care is provided at the right time to the right patient at the right venue or in the right venue. So to say that these organizations take patients or prevent attribution to freestanding or ACO organizations, you know, maybe there's some truth in that, maybe there's not. At the end of the day, we've got to make sure that all organizations, independent ACOs, are out here doing some of the same things, looking at the data, making sure the data that they're producing or generating shows positive results, and that they're communicating those positive results to their patients, their families, the communities, so that folks will want to come to their program and their attribution can grow as well. But we cannot get into this infighting and say that we can't go here or can't go there. Now, I understand health systems and some may generate or require a higher cost. I understand that, but we need to do a better job and make sure there's access for folks in all settings, you know, using a variety of partners.
And by the way, I didn't mean to leave out Paul. Humana's got a lot of primary care practices as well. So, Paul, if you want to take this.
So, thank you, Larry. So I look at these names, you know, Walgreens, CVS, Walmart, Amazon. What I see is trust, right? And those are trusted names. Whether you're shopping at the Walmart, you know, going to the Walmart Health, that's a big part of making a change and getting people access to primary care. So I think that that's important. Now, there's trust with physicians, like I mentioned earlier, but it's really giving patients that opportunity to understand what's in it for me. Why do I have to go to a primary care physician, right? I had a gentleman tell me a story about, you know, he and his wife just went to urgent cares and emergency rooms for anything that they needed. right? They didn't go to the primary care doctor. His wife wasn't feeling good. She ended up going to the emergency room, found out she had stage 4 breast cancer. It was too late to do anything. She passed away within a year, right? And the same day, another woman that is pretty well known in Jacksonville was diagnosed with breast cancer at stage 1. She went to her primary care doctor all the time. And so they were able to catch that early, right? So is being able to tell those stories about why it's important to go to the primary care doctor, whether it's, like I mentioned, faith leader or a community organization or somebody else telling that story to a member to get them to want to go to a primary care doctor. You can have an insurance plan and know that you can go to a doctor, but how many people do? Right? So how do we start getting people to go on an annual basis, showing them what's in it for me? How can we make an impact in their health? How can they feel better and have more healthy days back because they're doing this consistently and understanding the challenges that they face? So I see the trust with these names, and that's an important part, but it's also telling people and having people that look like them telling the story about why it's important to go to the provider as well.
Yeah, and I think this phenomena came from exactly what Paul is talking about, is the consumer wants access and convenience. And we have an access challenge with primary care in this country. And the ability to, have more access to primary care services that is fully integrated and supported. Because as I mentioned earlier, the primary care physician today is in a very tough position. And I saw one of the previous panels yesterday saying that based on a survey, 2/3 of the primary care physicians want to sell their practices. So that's why I personally believe of this value-based care model gives us the opportunity to support and enable these primary care physicians. So if they want to stay independent, they can, because now they will have access to the total medical cost dollars, not just the $100 per visit that is currently challenging to maintain and support the practice. So as part of the enterprise strategy to provide more convenient access with our community locations, we also believe that we need to have enabler arm to support primary care physician who wants to stay independent and provide them with the analytics and care management and the care team around them that help them practice at the top of their license. Because we all know a primary care physician today have 15 minutes on average with the patient. And some of these patients are very complicated. They have 5+ chronic conditions. And you cannot manage these alone in a 15 minutes. You need this care team. So that's why I'm a believer in the ACO REACH model and the various value-based care model that allow these physicians to have a care team and analytics at the point of care to support them.
Yeah, I would agree with all of the panel's remarks on this. And Larry, Guidewell Health does have some PCPs, so we can put our name on this.
I should have thrown you in there too.
I know. No, and it is about providing equitable access to care for everyone. And I think that is a tall order for our society and for our communities to achieve. And it will take any and every configuration of PCP provider types that we can come up with, I think, to achieve that goal. I think that being said, we really greatly value physicians that prioritize independence and that prioritize things like value-based participation. I think independent private practice has served such a critical role in our communities for a very long period of time. And we do see that whenever they're structured with clinically integrated networks, their performance is always better. Whenever we think about things like private equity, there's a lot of juice that comes there, so you get this energy, you get an infusion of dollars, you get resources. So I think there's some opportunities there where we could help people get better care with private equity-led initiatives. But I think where I would say I'd hedge on it a little is what's the long-term goal there? You know, is it a 3 to 5 year strike point with a turnover? Are we talking about something that's really going to have a lasting impact in our communities? Whenever we think about health systems, hospital systems, they're really not going anywhere. Like, I haven't seen them leave or you know, we have to work with them. We're going to work with them. Yep. And we've seen them actually, some of them do very well in value-based care over time. So I think leveraging all of what we have in front of us to ensure we can create equitable access for everyone. And I think it's a tall order that we're taking on.
Well, let me throw this just out to a couple of you, maybe Dr. Howell and Dr. Diab. In this same scenario, is it possible to manage costs in these types of environments, not being an independent physician?
I would say yes, but in order to do that, you're going to have an empowered consumer. Anyone that's been on a medical journey will tell you that the more information you have, the better decisions that you can make. Now, if you don't have any information, you tend to take whatever decisions are made for you. But when you have information, you have options. And many of our plans offer these kinds of information sessions, navigation opportunities, opportunity concierge practices that can help you gain information to make cost-efficient decisions. So yes, some of these, not so much these here, but some of the health system programs may cost more, but armed with information, I can choose whether I get my care, some of it, outside of the system, which is equivalent, or within the system based on what I need. So, you know, you can do it, but we're going to have to find ways to educate, and empower the consumer to be able to make good decisions.
And Dr. Diab, also in that comment about cost, is the continuity of care there for these types of organizations?
That's exactly what my point is. For any model of care to deliver a good outcomes, clinically and financially, it has to be integrated. Right? You cannot have a primary care in silo that is not connected to specialty care. It is not provided insight, actionable insight at the point of care, and care team to surround them. Because, you know, a transactional care that is siloed and it's fragmented never deliver good outcomes and never be able to reduce unnecessary costs. So whether these organization or any other organization, unless you have a fully integrated model of care that is armed by analytics and good insights, that is actionable at the point of care and fully integrated between primary care and specialty care, you will be a very fragmented and dysfunctional system. So it's incumbent upon these organizations, which mine is one of them, is if we go this route of primary care, we have to integrate it. And, you know, with the home care, with the specialty care, with the care management, that's how this would work.
Okay, thank you. You know, next question, if you could put up on the screen. We're going to kind of jump around because we'll never get to all these questions, and I would like for at least get a couple of comments from each of the payers, if possible, on some of these. You know, chronic illness management and chronic expenditures of health care, it's not the 20/80 rule, it's the 5/50 rule. On Medicare, 5% of Medicare patients represent 50% of the expenditures. And I was doing some research on Medicaid the other day. This number is going to blow you away. 1 to 2% of Medicaid members, recipients, which represents 86 million people in America, 1 to 2% represent 85% of the cost, the entire cost of the Medicaid program. So based on that, and Paul, why don't you start with this? How do we rein these in and how do we manage these chronic illnesses?
It's a great question. So I'll say my job exists because of this, right? Is how do we impact the health issues with our membership and how do we understand? It's really understanding what's happening in the community and around the community and looking at things like housing and looking at things like food insecurity and mental health challenges and how we can look at a whole person health model to impact those healthcare challenges. You know, we talk about diabetic patients. Well, a newly diagnosed diabetic patient is going to have some depression, right? They're going to have some mental health challenges, and that's going to lead to a big part of this healthcare expenditure. So how do we really connect the resources, you know, internally within Humana, but externally within the community? You know, I look at physicians like Dr. Lee over here, so sorry to call you out, but he really understands, you know, wrapping additional services around taking care of the member, right? And really digging into those social determinants of health. So when myself and my team work with United Ways or the food banks or the area agencies on aging, it's not only understanding, you know, the challenge that exists within the community, but those people that have serious expertise in this. You know, I don't know everything about social determinants, but I know a lot of people that do. And it's really connecting those dots within a community, within an organization to make some change. You know, one of the other things I'm working on in Jacksonville with the City Council is improving access to healthcare within our community. And that's an important component, is looking at policymakers that can change things, whether it's Jacksonville Transportation Authority that's providing additional bus routes, or, you know, smaller vans that can get deeper into the community to get people out, or where do we bring healthcare to people, whether it's our healthcare at home models, right? And we talked about you know, remote monitoring as well, right? Is if a person can't leave the house, what do we do, right? How do we get them food? How do we get them a social connection? How do we understand their disease? So that's what my job gets to impact this part. So I would say, we've planned it. You know, Humana's been doing this Bold Goal Initiative, our population health strategy, for about 8 years now. You know, I've been fortunate to be doing it for about 6, and that's what we're doing. And we're continue to build off and learn more and learn from the experts within the communities and our provider groups to help understand those challenges that the patients face.
And that's great. Yeah, and you know, I think I was looking at this question and curious, seeing the CDC reporting like 60% of Americans are living with one chronic illness and 25% are living with 2 or more. You know, I think it's something that will await us all if we don't address it long before the time comes to seek health care. You know, it's really in the foods that we eat, it's in the way that we work, it's in the way that we live, it's in our communities. From a value-based lens, whenever you kind of say, okay, well, how does this apply in the work that we do? I think a lot of it's in pinpointing opportunities, identifying care patterns, which really, again, boils down to the challenge we opened with about data, analytics, how we have different models of care where we could measure different kinds of chronic disease, make it more of a focal point for our value-based arrangements in the community. So you'll see things like co-attribution is a concept coming up where you're identifying more than one physician that's engaging that patient to manage care, being able to align our models to where they foster PCP and specialist integration. You know, we're in years past, I mean, kind of a lot of this is primary care engagement. You know, so we stand up a total cost of care arrangement. We're working with PCPs, and they can do a lot. But I think really to be able to fully address this, we have to create some type of an incentive system that flows all the way through the delivery system and starts well before the point in time of care.
Yeah, but I think this is a selling point for value-based care. Yes. Because for value-based care, now that I'm, you know, accountable for the population, I start looking to prevent these chronic conditions from happening upstream. So I start talking to the population around weight loss, around exercise, around stop smoking, around these kind of activities that prevent the development of diabetes or hypertension. Or so that's actually different than the sickness system that we have in a fee-for-service, where I have to wait until the patient come to me because they have developed these chronic conditions. Then I'm also incentivized in a value-based care to close these gaps in care and reach out to the population using the data to identify these clinical gaps in care and addressing them, and versus a fee-for-service system where a physician would wait for the patient to show up in the 4 walls to start intervening. So this is, you know, it is using the data, to identify the prevention early on and early detection of rising risk in the population and addressing them. And then, like Paul said, one of the major challenges is, and we heard it yesterday in one of the panel, is patients who are not adhering to the treatment plan. Yep. And in many cases, I see this is, like Paul mentioned, driven by behavioral health issues. And, I ran analysis of people who have diabetes alone versus people who have diabetes and comorbid diagnosis of depression or anxiety. And you see the cost doubling and tripling because these folks stop taking their meds and stop doing their hemoglobin A1C, and they just don't care. So addressing the behavioral health and having solution to address this for chronic condition patient becomes very critical. So again, the best way for chronic condition management is having a value-based care and having a care team around the physician who work on closing these gaps in care. One of the things we are doing at CVS Health is we're using the pharmacist at the point of care and the nurse practitioner in Minute Clinic. So when a patient comes to the pharmacy to fill a prescription, a pop-up comes in the screen in front of the pharmacist saying this patient have these clinical gaps in care. And because the pharmacist is one of the most trusted provider in the healthcare, they have like 80% closure rate of these clinical gaps in care, right? So this is just an example of when you have an integrated system, which Larry, we were talking about, it's an integrated, you use every intervention available to work on these patients to close gaps in care and improve the outcomes.
So I would just add very quickly, and Dr. Diab kind of hit on it, we've got to integrate lifestyle medicine into what we do. And we've got to integrate it at a far earlier age than those that are 65 and older. The damage is done then. As we were talking about the genomics, the DNA is already ruined at that point. Got to integrate lifestyle medicine. The other thing is we need to remove the stigma of chronic disease. People don't even want to talk about the fact they have hypertension and diabetes and arthritis. It's something they keep close to the vest. And I tell you, until we can talk about it candidly and openly and start sharing what did you do to get your blood sugar down or to take care of your back issues? Until we can start doing that, we're never going to get out of this hole. We need to connect resources to the needs of the people. We've talked about that. And the final thing, it's something that we in America don't like to do. It's okay to ask for help. It's okay to ask for help. Because when you ask for help, you know what? A lot of times folks will step up and help you. And we see it every time after a catastrophe or a crisis in this country. Now, when this crisis and catastrophe is over, we go back to not offering any help. But when we do that, that's who we are. So I think we've got to be okay to asking for help.
Thank you, Dr. Howell. We're going to combine these next couple of questions and maybe just ask a couple of our panelists. But we're talking, next question on the slides, talking about patient engagement and ownership of one's health is a must in the future of a healthier America. And then we're talking about provider and physician engagement as to how do we get these people to transition, our doctors to transition into a value-based care environment in their practice. Ray, you want to take that?
Yeah, I think so. For us, as always, our members are our reason for being. That they're why we exist, and we have existed for 75 years in the state of Florida. We're always looking for ways to connect to people, and that's always changing. But I think we want to find their preferred mode of communicating and gathering information so they can get healthy and they can stay healthy. So, as you could imagine, value-based care is something that's present in our touch points with our members. From the moment they're picking their plan, to the moment they're looking for a doctor, to the moment they're calling for assistance. We're really highlighting for them the familiarity with value-based care. What does it mean, to have a team-based, person-centered, financially aligned opportunity for care, and really why that's the best option for meeting their healthcare needs, and working with our employers as well to highlight that for the community. But I also would say that the doctor's communication to the patient is paramount. about value-based care. I think that's their trusted advisor for their health more than their plan is. And physicians in general, I think we've seen a lot of great adoption and engagement around value-based care over the last 7 or 8 years.
Yeah.
In terms of what do we do to get the rest on board, that's I think, the million-dollar question.
It is.
And do you force it or not? And so I think we're looking at what's going on in the state legislative process.
What are financial incentives as well to the physician?
Absolutely. So there are a lot of things I think we need to get done so that value-based care becomes an expectation for our communities. It's not an add-on. It's not something we kind of are curious about and maybe we want to do it. It's something that's just whenever you start to purchase health care, value-based care is what you're purchasing. And I think we've got some distance to cover before we're there.
Dr. Howell, do you have a comment on that?
As I see this question, I have to just go back to starting young and making it part of our genome that good health is to be expected. Right now, we all expect to decline in old age. And we lost some years in longevity during COVID, I can get that, but we've got to figure out how to get those years back. And in order to get those years back, we're going to have to start young. And I mean, there was a program I was involved with early in my career where we actually taught hypertension education to, I believe it was 5th graders, because the goal was to make sure that they understood how that disease could impact them at a much later age. I think we've got to start talking about this. We talk about everything else in school. I would guarantee you 90% of that nonsense we had to go through, we don't even use now. I don't even know what to do with the slide rule, but I had to learn how to use it. But if I had to learn nutrition, lifestyle modification, disease management, at a basic level, I can learn how to eat better, exercise better, maintain my weight better, sleep better, manage my behavioral health and mental health better. So that's how I think we need to start and to really integrate that into our educational system as we grow throughout our lives.
So I love what you were saying, and I think that's a big part of it is, who's telling the story and how do we give people a demonstration that they don't have to grow up the same way that the people that they live with did, right? If my grandparents had diabetes, my aunt and uncle and everybody else had diabetes and they had an amputation, just because I live in the same community and I grew up the same way doesn't mean that I have to lose a leg or I have to have diabetes, right? Is how do we make those changes at an earlier level? So I think that's part of it, and telling the story and who tells the story, whether I go to it or, any of us are there, or a faith leader or whoever it's going to be that's telling that story about engaging and the why to make a change. And that comes to the health equity piece, right? If they understand that it doesn't matter what I look like and where I grew up, I still have the opportunity to be the healthiest and happiest that I could possibly be, that's a big part of this. So we've got to make sure we've got the right people telling the right story to the individuals at a time that they can make a difference in their health.
Thank you. Dr. Diab, would you hit on health equity for a minute?
Yeah. Health equity is very near to my heart, and I always feel ashamed that we live in a society where 2 adjacent zip codes have a 20 years difference in life expectancy. It should make each and every one of us ashamed and embarrassed, right? So we as an organization are investing heavily in collecting the data, creating this mechanism to understand our customers and our members and our beneficiaries and identify where the areas that creating barriers to care, where the areas that we can help and support and make a difference. But I'm also a believer that you cannot make the perfect the enemy of the good, right? There is a lot of things that we can do without waiting for the perfect data collection, right? And as simple as I asked my analyst one day, can you please run me the utilization and chronic condition prevalence by zip code for this population? And the data jumped out of the page that these 2 zip codes have higher prevalence of chronic condition, much higher utilization of ED and admission and readmission, right? So we all have access to data that we can start with, but we are investing in this heavily, and I'm so proud that CMS finally is pushing all of us through the ACO REACH program by making health equity is a focus of the program. And we are creating a database for our population that have multiple variables to understand what's going on, but it never stops here. Because if you have the data, then what, right? What is the intervention and how we can make a difference? And as the panel said, there are a lot of items that we can make a difference fast, like food insecurity, transportation issues that's creating barriers to care. There are items that is harder, like housing and other stuff, but there are things that we can definitely remove this barrier to care and work closely with the community programs that is available to create these interventions to make a difference in people's life. And our foundations and our social responsibility teams are working significantly on trying to create these solutions for the population.
Thank you. I want to start down on your end, Dr. Howell, and just final comments, very short, from all four of you, because I want to leave just a couple minutes open for a couple questions from our audience.
I think the journey that we're on now, we're really just getting started. We had, like I said, we had momentum. COVID stopped us dead in our tracks. We've got to really put some time, energy, resources, expertise into getting back up to speed again and really surpassing where we stopped or were delayed with COVID. There's a lot of work to be done, but we've got to engage it and we have to be successful in it, because if we don't, healthcare is going to break the bank. It's already teetering on being broken now, but we're going to have a population that's not going to live healthy, and we're not going to be able to afford to take care of them.
Yeah, and I'll just be really quick, and we have to look at ways to collectively impact this issue, right? Is not just the traditional healthcare stakeholders of the hospital systems, the provider groups, and others, but start to look deep upstream, on the real challenges. How does a patient take care of themselves and exercise if they're diabetic, if they're afraid to walk outside and get shot? Or, slip and fall on a sidewalk that's overgrown, right? There's other people that need to be involved in these conversations, and we need to not be afraid to tell that story to anyone who listens, because we can't impact it ourselves. We have to impact it with the existing infrastructure within a community, but then start to bring in our, businesses and policymakers and others to make a sustainable change. I always tell our nonprofit partners, yeah, I'll write you a check to do something, but that's not sustainable. We have to figure out a plan to make this sustainable. And I'm not just going to write a check that I'm going to have to write every year. We've got to bring those other partners in that are going to make a difference.
So for me, I just wanted to say thank you to all of the value-based partners that are in the audience here today. I think you are really what's keeping the movement moving. The payers are only one piece of the puzzle, and I think your commitment and ongoing learning and energy and dedication is what I think has helped us emerge from the COVID-19 pandemic and really shift our focus into not only how do we take the good work that we've done over the last 7 or 8 or 10 years and really keep it relevant and sustain it, build it to last. Talk about all the things that this panel has brought up in terms of health equity, behavioral health, community engagement, but also think about the care delivery continuum. How do we take every single provider that's involved in caring for a patient and help them understand value-based care? Help them understand where they fit into the value-based care puzzle. So I think that remains to be one of the biggest challenges I see out there, is if we stand up episode-based payments or bundles and we do it in a fragmented kind of way, we're not really helping people get a better overall experience, and we're not going to do justice to the value-based transition. So for me, it's thank you first and foremost, and let's keep going. Let's transform and change what we're doing to build this to last.
Yep. And I want to echo everything that the panel said. Thank you so much for all the work that you're doing to improve the quality of care and the health outcomes for the population in Florida. And if there's anything we can do to support you and help you in this, we would love to do that. And it takes a village. You know, be successful in value-based care is not an easy task. You know, transforming the way we deliver care in the United States is not easy. It takes a lot of effort. It takes a lot of cooperation between payers and providers and even the population itself and the community programs and community resources. So we all have to work together to make a difference. And, you know, we all are consumers of healthcare. So this is going to impact us as consumers and our families and our kids and the generations to come. So it's incumbent upon all of us to change this system to be a better system for the new generation that is coming. Thank you.
Great. A couple questions from anyone? And also, after the panelists were finished, they encourage you to come up, introduce yourself, and ask them any questions that you did want. But are there a couple of questions that you'd like to ask from the audience right now? Okay.
Thanks, Larry. Bill Lane, I'm Senior VP, actually Executive VP. I just demoted myself of Illumed. Paul, this question is for you. Relative to you being part of Humana's bold goal by 20% by 2020, lessons learned, any takeaways from that that you could share with us?
Yeah, so we changed the 20% by 2020 since we've already passed that, but now it's just really giving people more healthy days back. So I think that lessons learned is don't be afraid to fail when we're doing something, right? If there's a good idea, let's give it a shot and let's see and let's pivot and change if we fail. And I think that it takes a little bravery, it takes a little patience, it takes a little time to really change where this healthcare train has been, right? Focusing on reaction to care instead of prevention of disease. And so we've really learned a lot by partnering with our community organizations to understand people and understand the history of a patient going to the doctor's office and how they were treated and how we get people to think differently about different cultures. You know, that's all learning that we've had. So I think, you know, in the 8 years of this Bold Goal program that Humana has been running, we've learned a lot, we've shifted a lot, and there's still a long way to go.
One more question. Anyone?
Yeah, no, thank you. John Pagan, I'm from the PA Clinical Network, independent practices across the state, as well as an ACO, and I thank all of you for being here, and I thank your enlightened goals. You come from big organizations. Even the value-based units within those organizations sometimes can be bureaucratic and fairly rigid. I like what you just said in terms of trial and error and learning. We're all learning. This is a beginning. This is a continuum. Health is a lifetime thing. Unfortunately, disease doesn't follow a calendar, and a lot of times your performance years and your metrics and your deadlines don't really match the desperation of the independent physicians and the practices out there. So it's such a long delayed gratification game, looking at the data, closing the gaps, looking at the goals, looking at the savings that the docs are doing something good today. They don't see that for months, even over a year. Any ideas on sustainability or getting us to the point where that, because literally day by day, these doctors are making tough decisions and they're either going with the big hospital or the big institution because they can't sustain.
So I think this is one of the benefit of the ACO REACH program is because it has a prospective payment option to it. So you can provide the primary care physician an advance payment to materialize the effort that they are putting. And the reconciliation component of this happen much faster than the traditional models of MSSP. So this is one of the advantages that CMMI built into the ACO REACH model, is giving the flexibility of advancing the payment to the primary care physician and also doing the reconciliation so they can reap the benefit of the savings early on and not wait 18 to 24 months to start seeing the money. And that's, one of the tools in ACO REACH to help the primary care physician to have access to the higher dollars.
I want to thank our payer panelists for coming in and taking their valuable time. Relationships are everything, and payer relationships are the most important in all the things that we do. And I want to commit from our FLAACOs organization and all our providers that we will work with you as close as we can to meet the goals, and those goals are better patient outcomes and lower cost. We know that today we're a $4.6 trillion industry, going to $8 trillion by 2030. And if we're going to rein in healthcare costs, maybe we can knock a couple trillion off of that between now and 2030. But let's thank our panelists.